often people said they would do things, and that just didn't show up when we looked at their actual vaccinations. So many of the public health messages we used seemed to increase the likelihood that people said they would get vaccinated in the next, say, 30 days. But then when we looked at the actual data, that wasn't the case.
From the USC Leonard Davis School of Gerontology, this is Lessons in Lifespan Health, a podcast about the science and scientists improving how we live and age. I'm Professor George Shannon, Kevin Shue Chair in Gerontology. On today's episode, how Professor Mireille Jacobson is uncovering connections between health policies and well-being. Mireille Jacobson is an associate professor in the USC Leonard Davis School and a co-director of the Aging and Cognition Initiative at the USC Schaeffer Center for Health Policy and Economics, where she's also a senior fellow. She recently spoke to us about her research using economic insights to better understand decision-making around vaccines, palliative care, Alzheimer's disease, and more. Welcome, Professor Jacobson. It's a pleasure to speak with you today.
Thanks so much for having me. It's great to be here.
Well, I'd like to start with some general questions. Can you explain what health economics is and the role it plays in healthy aging?
Yeah, certainly. So health economics really is just the application of economics to health and healthcare. So we kind of need to take a step back and think about what is economics. And I find that a lot of people think economics is kind of the study of the stock market or money or GDP, interest rates. And those are actually all things that economists and economics kind of study. But economics itself is actually kind of a more fundamental topic about how decisions are made when resources are scarce. So whether it's time or money or attention, we all have to kind of make what we call trade-offs. So health economics is really thinking about how to make choices in the context of healthcare and health. In the context of healthy aging, economics isn't just relevant, but I think really critical to understanding things like how to incentivize healthcare providers to coordinate care or encourage people to save for retirement.
So life is a series of trade-offs, as we all know. I understand you recently looked at a social phenomenon you call nudges and their ability to influence COVID-19 vaccination rates among vaccine-hesitant individuals. Can you tell me what you found?
This was a collaboration with colleagues at USC, UCLA, and Contra Costa Health Services, which is the Department of Health in Contra Costa County. They also run the Medicaid managed care plan there. And although the county did an amazing job of getting its residents vaccinated, actually amongst the best in the whole state of California, the managed care plan, the Medicaid plan, there were a lot of people who were yet to get vaccinated despite kind of months of eligibility and kind of ample supply of vaccines. So they were kind of the vaccine hesitant. And we wanted to understand, could we increase vaccinations for them? And could we do it using what you just called nudges, behavioral nudges? So this is the idea that I can kind of make small changes, whether it's, again, financial or non-financial, and kind of encourage people to overcome things like inattention, forgetfulness, just common psychological biases to help them get to, what we think is a public health, socially desirable place of higher vaccination rates. So what we did is we invited unvaccinated members of this health plan, this Medicaid plan, to participate in a survey. And some of the people who were in the survey were randomized to receive an offer of financial incentives, either $10 or $50, if they got vaccinated in the next 2 weeks. Some people saw public health messages, several different kinds of public health messages that we used in the survey. And others got access to kind of an easy vaccine scheduling link. And I should say all of these, what we call interventions, were crossed. So some people got none of them, and some people got financial incentives and a public health message and an easy vaccine scheduling link and kind of everything in between. And then after the fact, we looked at both what people said they would do. So did they say they were going to get vaccinated after they saw our public health message? And then more importantly, did they actually go get vaccinated? And unfortunately, none of our nudges actually moved the needle here. So we just found that unlike in other contexts like flu vaccinations, where we know that financial incentives can really increase uptake, that didn't work in this context.
So understanding the reasons for people's hesitancy may or may not have influenced the impact of the messaging.
Yeah, no, this is kind of a great point. And in fact, when we kind of looked at the data more finely and tried to kind of see how different groups responded, we found something actually somewhat troubling, which was that while as a whole, people didn't respond to the financial incentives, people who said that they supported Trump in the 2020 election, for example, were less likely to get vaccinated if we offered them a financial incentive. The same is true for the kind of older respondents in our survey. You know, the people on the really 65 and over, and most of them had gotten vaccinated. But if we look at the people 40 and over, if we offered them a financial incentive, they were also less likely to get vaccinated. So there were kind of groups that held very strong beliefs about, I would say, this is how we interpret the data. They had very strong beliefs about COVID-19 vaccinations kind of not being a good thing, and offering money to them seemed to kind of reaffirm that for them and encourage them to dig in their heels further, I would say. So that was really an unfortunate finding.
So that was a surprise, I'm sure.
Definitely a surprise, I would say. Others, so George Lowenstein, who's a behavioral economist at Carnegie Mellon, had predicted this type of response pretty early on before people were running these types of experiments. And I mean, the reason I'm so excited about this project is there's been so much discussion about how to move the needle on vaccinations, but really very, very little data on actual vaccinations. So most of the work in this area has been for expediency reasons. I mean, I understand, but most of it has been focused on what people would say they would do. So you'd say, if I gave you $50, would that increase your likelihood of getting vaccinated? And we were able to both ask that question as well as look at people's actual vaccinations. And in fact, the funny thing is that we found that often people said they would do things, and that just didn't show up when we looked at their actual vaccinations. So many of the public health messages we used seemed to increase the likelihood that people said they would get vaccinated in the next, say, 30 days. But then when we looked at the actual data, that wasn't the case.
So it's like that kind of old joke, if I offered you $1 million, would you consider being vaccinated? And then, of course, everyone would say yes. And then, so tell me the number, give me a number between nothing and $1 million that it would cost us to get you vaccinated, to see if there was any kind of a reliable response, right? So we don't know then. You don't know. And obviously from what you said, I don't know what interventions might be effective in boosting COVID-19 vaccination rates. Obviously the money didn't work.
Yeah, I mean, I guess there's a caveat there, which is that we were using what we call small financial incentives. So, you know, the idea of a nudge is to kind of, I mean, just like the word itself, kind of a small change. I think if you probably offered people $1 million, they would get vaccinated. They would overcome some of this kind of, I don't know, hesitancy is not even the right word, but strong dislike of being required to get vaccinated or being encouraged to get vaccinated. It's just, you know, that's not within the budget set, right? We have that the idea that we have to make trade-offs. We can't pay people $1 million. So that's not an option. That said, you know, we are considering trying to plan an intervention with the health system in Contra Costa where they would offer people much larger amounts. So something more on the order of $250. You know, that is much different, 5 times more than what we offered, and maybe will help people overcome their reluctance to get vaccinated, but we don't know. I guess the second thing I would say is that, you know, I think we have quite a bit of evidence now from mandates, either explicit mandates or kind of what I would call kind of implicit. So Delta Airlines said to its employees, you don't have to get vaccinated, but by the way, you're going to have to pay $200 more per month for health insurance if you don't get vaccinated. So that's not a mandate. People can decide, I don't want to get vaccinated, but they'll face a really steep cost. And I think vaccination rates at Delta are 90% or higher. So I do think we have some sense from these types of interventions that can move the needle quite a bit. I actually just saw someone tweeted about the University of Kentucky. So Kentucky is not a state with very high vaccination rates, but the university is at 99% vaccination rates. So pretty impressive.
Yeah, that really is. So let me ask you about your work with Contra Costa County. Is that continuing? And what are you looking at there?
Yeah, so we started this collaboration when COVID hit. At first, we were helping them look at ways to get people tested for COVID. This was before vaccinations. They were really concerned about particular communities of color that were at really high risk of COVID, but weren't getting tested. So we worked on that. Then we did this work on vaccination and COVID vaccinations. And I should say that's kind of ongoing. But we're really starting to kind of think more broadly about healthcare in their system. All Medicaid plans in California are subject to something called a quality incentive pool, which is kind of a pay-for-performance program to try to encourage them to increase rates of mammography screening and colorectal cancer screenings and actually advanced care planning conversations. And so right now we're really in the early stages of thinking about how to kind of improve outcomes on these measures, while also they're very attuned to the fact that there's this great proliferation of kind of checklists and that this can be frustrating both for doctors and patients. So the example they always give is, someone comes to the health center and they have a cough. And now the staff wants to know, did you get your mammogram? Did you have an advanced care planning conversation? And they just want, someone to help them with their cough. So those kinds of issues of how this affects kind of patient, I guess I would call it satisfaction, but experience, as well as provider experience and burnout are going to be kind of two core issues that we think through. And I should say we actually just found out that we got pilot funding to support that work. So we're really excited about that.
I understand you've looked at the role of economics, or follow the money, in understanding rates of palliative care usage. For starters, can you talk a little bit about what palliative care is and what the known benefits are?
Sure. So palliative care is care from a team of specially trained doctors, nurses, social workers, and chaplains who focus on improving quality of life and reducing the disease burden for seriously ill individuals and their families. It can be provided alongside other treatments to people of any age facing serious ailments. The focus is really on treating pain and other distressing symptoms, addressing family needs, coordinating care, really focus on kind of the quality of life of patients and families. And there's actually a wealth of evidence that palliative care can improve quality of life. There's a now famous study for patients with advanced lung cancer that showed that those receiving palliative care, in addition to regular treatment, not only had reduced symptoms of depression and lower likelihood of hospital admission, but also improved survival than those who received regular care. Kind of a stunning finding.
Well, I was going to say that's a really wonderful finding. I did a study once where we found that just a telephone intervention once a month actually sustained life among homebound older adults. So, I mean, some of these interventions are shocking. I was looking at some economic numbers yesterday. There was a presentation in one of my classes, and in every area of cost, palliative care knocks the prices down by, 13, 15, 20%. And that's, when you're talking about Medicare numbers, that's a lot of money. Why isn't it more widely used? What's stopping people from getting in there sooner?
Well, I would say sometimes, a payer's savings is a health system's loss, right? So the incentives really matter to the extent that palliative care saves money through a reduction in kind of unnecessary treatments or hospital readmissions. I think traditionally in our healthcare system, that meant a loss for healthcare providers. Our system's really changing, and hospitals increasingly from Medicare have incentives to kind of lower spending. And so maybe we'll see more of a push towards palliative care and a growth in the next, decade or so. But I think really up until very recently, it was really at odds with providers' incentives to widely offer palliative care.
Those are the same conclusions we came to yesterday when we were discussing it. Let me switch a little bit. Speaking of economics and cost of care, I'd like to ask you about your research concerning Alzheimer's disease.
Yeah, so this is work that I'm doing mostly with Julie Zissimopoulos at the Schaeffer Center. And she's really the kind of Alzheimer's disease kind of expert. Where I fit in is really thinking again about like incentives that different payers face and how that kind of relates to Alzheimer's disease. So we've looked at screening in Medicare, for example, and found, perhaps not surprisingly after the fact, that beneficiaries who are enrolled in Medicare Advantage, kind of private Medicare plans, were much more likely to say they had received cognitive screenings. So to identify or to kind of set people on the path to identifying Alzheimer's disease or other related dementias than individuals who are enrolled in traditional Medicare. And why I say that's not that surprising at the end of the day is that Medicare Advantage plans get paid for their enrollees based on what we call a risk-adjusted payment. So based on the severity and extent of disease facing their beneficiaries. And so people have found that they're actually kind of do a better job of screening in general and identifying health conditions of their members. And so this kind of carried over into cognitive screenings in the work that we've done. We're also looking right now at kind of the time path or trajectory of treatment for people who are diagnosed with Alzheimer's disease or related dementias in Medicare, both in, again, traditional Medicare and this Medicare Advantage or Medicare managed care plans. And what we find is that actually people in traditional Medicare, where care is very fragmented, are much less likely to be diagnosed outside of the hospital, or said differently, they're much more likely to be diagnosed in the hospital than those in Medicare Advantage. And their kind of rate of hospitalization and other service utilization remains much higher than those in Medicare Advantage. On top of that, it looks like they're also much more likely to die within a year of their diagnosis. And all of this at least seems to suggest that care really is not as well managed in traditional Medicare plans.
So what has your research in Alzheimer's revealed through screening and treatment?
Yeah, so work I've done on Alzheimer's disease has really been focused on kind of screening and treatment and differences that we observe in traditional Medicare and Medicare Advantage, which, as I said, is Medicare provided by commercial health plans. So again, this is work with Julie Sissimopoulos. And in our initial work, we asked seniors about their prior experience receiving cognitive screenings. And interestingly, we found individuals enrolled in Medicare Advantage plans were more likely to report that they had received cognitive screenings. So MA plans get paid in part based on the disease burden and severity of disease of their enrollees. So we suspect that MA plans put a greater emphasis on screenings generally, and that this is reflected in cognitive screenings as well. But I should say that the whole idea of screening people for cognitive decline is actually quite controversial. So the USPSTF, the United States Preventative Services Task Force, actually rates cognitive screenings as we don't have enough information to recommend it in routine care. And I think the reason is partly because we don't actually have curative treatment for Alzheimer's disease. I would say the experts that I work with in this area, though, feel very strongly that kind of screening early is really important to help people, if not through curing their disease, but helping them plan for the future. So that kind of motivates our work in this area. We also have ongoing work on, as I said, the trajectory of treatment in Medicare Advantage and in traditional Medicare. And somewhat to my surprise, it really does look like at least people living with dementia have much better coordinated care in Medicare Advantage plans than fee-for-service plans. That's what our early work is showing. And we are kind of continuing down this road.
I mean, we struggle with trying to come to conclusions based on, what is, from the beginning to the end of this interview, somewhat irrational behavior on the part of various segments of our population, including the people who need healthcare and the people who provide it. What are the future goals for your research?
I think most of what I like to do is to try to take what people think are kind of commonly held beliefs or their instincts about whether it's COVID-19 vaccinations or advanced care planning conversations and try to test them with data. So increasingly, I'm doing that with what I call kind of pragmatic randomized controlled trials, much like we did in Contra Costa with vaccinations and work I'm doing in Minnesota on opioid prescriptions. But also sometimes you just need to go to the data, to the Medicare claims, for example, or what we call the Medicare encounter files for people in Medicare Advantage plans and just see what is going on. So I think that's kind of really what motivates me at the end of the day, finding data to ask what's happening and, can we improve outcomes for patients, for providers, really for everybody.
Well, thank you so much for speaking to us. I've really enjoyed this conversation. That wraps up this lesson in Lifespan Health. Thanks to Professor Mireille Jacobson for her time and expertise, and to all of you for choosing to listen. Join us next time for another lesson in Lifespan Health, and please subscribe to our podcast at lifespanhealth.usc.edu. Lessons in Lifespan Health is supported by the Ney Center for Healthspan Science and by the Center for Lifespan Health.